So I'm going to talk to you today about, this is another device that is not FDA approved at this point. I have no disclosures that are relevant to this particular talk. So with mitral regurgitation, we're all aware that it occurs, some of it we see, some we don't see. There's a fairly high incidence of 3 to 4 plus MR in the population, which, like most cardiac disease, increases with age. And by 2020, it's estimated we'll have about 5 million people in the United States with 3 to 4 plus mitral regurgitation. Now, not all of them are symptomatic, so some don't come to see us, but a good portion are not referred for surgery because of the high risk of disease. And where this is relevant, if you look why we would want to run a great operation with another transcatheter procedure, a European heart survey showed that about half of the patients with severe mitral regurgitation are denied surgery because of age, comorbidities, or poor ventricular function. Well, as you've heard earlier, there's been an explosion of TAVRs with over 100,000 implants since this all began in 2007. And since the first implant in 2014, August of 2014 of the Tendyne, there's been a whopping growth in TMVR implants, now less than 30 worldwide. So this is a procedure that's in its infancy and has a lot of challenges with it. As we all know, there's different etiologies, and that just with surgical approach, a transcatheter approach to different types of mitral pathology may differ. And a part of this is from just dilated cardiomyopathy, whether you have asymmetric or symmetrical tethering, whether you have degenerative disease. And the anatomic challenges are a little different than with aortic valve, where you have stenosis, you have a tube inside of a tube, and it's pretty straightforward. Whether it's more elliptical or not is kind of the biggest issue. But with the mitral disease, whether you have calcification or not, how are you going to anchor the valve? It differs. Annular calcification can affect seating of the valve and sealing. And then, of course, if you have complex subvalvular anatomy, for example, if you have a flail anterior leaflet, that's probably best addressed with a different technology, but could produce issues with LVO tract obstruction. And similarly, if you have a hyperdynamic small ventricle, that's probably not going to be an option with the current devices. So if you look at the assault on our approach to mitral disease, you can see here that there are a bazillion different products and billions of dollars being deployed in this. If you look strictly at the mitral valve replacement, there are 4 devices which have been trialed in humans. Currently 3 are being utilized, and there's really only one FDA-approved device up here, and that's the MitraClip. The Tendyne valve, if you look at the different valves that we see here, they're all a little bit different, and they have different anchoring and so forth. The Tendyne valve over here in the lower right corner, I want you to look at. First of all, you notice that it has these wings that stick out from the side, and that'll be important to look at later on. And then it has a larger lip. This is the atrial view of this valve, by the way. This lip that folds up in the atrial septum, and part of this is for orientation and seating. So here we have the valve, and there's some features about this valve. First of all, it's self-expanding. No balloon expand to seat it is necessary. It's porcine pericardium. It has this large skirt, which aids in seating, and it's cloth covered to help protect the leaflets as well as to aid in the seating. So some of the things, it has this tether. The way this valve is deployed is transapically, and this button sits on the outside of the ventricle, and this tether is what keeps it from flopping back into the atrium until it can heal in. It does not require any sort of support to put in, and as such, its implant is quite smooth and easy. It comes currently in 23 different sizes, which is a lot, but again, this is the beginning of this. We'll see where it goes. And the deployment, as you'll see, is very simple. It's controlled and fairly relaxed, actually. And most importantly, it's repositionable and fully retrievable. After the device has been completely deployed, you can still get it back out. So this is an important concept for this device. So in the Tendyne IDE study, there are 11 sites, and 2 of which have been activated in the United States. And as you can see at Baylor, we are the 4th leading experts in the world on this valve with our series of somewhat less than 100. As I understand it, with an N of 21 at year's end, 2 more have just been enrolled, so we're up to 23. But for the purpose of this, you can see the majority of patients are male. Class 2 and 3, all patients were in these 2 classes. Class 1 clearly not needing the treatment, and Class 4 being contraindication. And most all the patients are functional mitral regurgitation. So if you look at this, this is the busiest slide I have here, thankfully. So this is AP diameter, this is lateral diameter, and you can see these different dimensions here in diastole. And the point is that this device can be used to treat a wide range of patients with different regurgitant pathologies. So the valve requires quite a lot of imaging to assess its size. And so primarily in systole, the minimum size of the annulus that we're going to have is key for the size of the valve itself. And then there are other images that are important. So the CT image here, it's about an 8-centimeter deployment sheath. And what you see here is this line here is not going out to the true apex, and there's a reason for that. This entire setup is done on CT. A 3D image is made to help define the optimal penetration point for the valve. 2 other things. The valve, as you saw in profile, is kind of large, and then at 9 millimeters inside the ventricle, it starts to taper down to its cone shape. And this is important because we need to have a centimeter of clearance between this device in here and the septum to prevent LV outflow tract obstruction. And again, that's part of what the mitral and aortic angle helps us define where the puncture point is going to go into the ventricle to orient this away from the septum. So the thing about these valves is they're large, and right now the only approach for these types of devices is transapical. My associate Paul Grayburn says it's kind of like putting a beer can inside the heart, and he's not too far off in that regard. So current iterations are a surgical procedure, and this is the procedure where the cardiologist stands in the corner, because other than the echocardiographer, they really don't have a lot to offer here. So let me run through the implant here. It's pretty simple: access, delivery, and finalization. So this is the small left anterior thoracotomy, and at the beginning we do a surface echo to confirm that our site identified on CT scan is where we want to be. This is typical apical puncture inside of a purse string. Here's the wire going in. The catheters are for pressure monitoring and part of the study recording, as well as just, now here we're taking a Fogarty and going across the mitral valve so as not to entangle any of the chordae. In comes the stylet here. And actually this imaging is unnecessary. You can do everything by echo, and that is the preferred modality actually. So here's the trocar, or the introducer catheter, and this is huge. It's 32 French. So you thought the Sapien was big. This thing is really enormous. So we see the device inside here, and again, all the visualization is done, the imaging is done by echo. This is done to show the valve in its compressed state being extruded into the atrium. Initially, we deployed these in the atrium and pulled them down into place. However, that didn't always quite seat so well, so now our technique is to employ partially intraannular with the final seating. So here you can see the device is starting to come out. This is a little bit fuzzy, but you can see the valve opening a little bit right here. And this is a device up in the atrium. You can see it rocking around a little bit. You can see the extensive cage for this and the tapering that occurs, again, starting about a centimeter below the into the ventricle. So there's the valve. Not the best image. Now this is the valve being tugged on to try and get it to seat and into position. And you can see quite a lot of pressure being pulled on this valve as part of the introducing device was withdrawn out to the apex and the purse strings are secured. And here the valve is in place, and the thing you'll notice over here is it's not well seated. Valve is functioning normally, very pretty up here, but it's not well seated, so again, a little tethering, pulling on it to get it to redeploy. The valve is repositioned. You can see it deforming there as it's seating down. Quite a bit of snug pulling on this. This is recording the pressures now. Angiogram shows there's no interference with either the arterial or vascular circulation, or venous, excuse me, circulation. And so this is the recovered valve, and you can see the valve's opening very nicely, and there's no leak identified around this valve. Well, to kind of show you the recapturability of this particular device, this is in an animal model, but here the device is being, again, resheathed, recaptured, and as it's compressed, it pops right through the mitral valve and can be completely withdrawn and none the worse. So let me talk about our extensive series here. So the first patient was a male who was deemed to be poor risk. He had a dilated cardiomyopathy, which an ejection fraction of 30%. That's the lower cutoff on these patients. We're not looking for people 20%, 15% because of the higher risk of those folks and the questionable benefit from doing this procedure. He was as unenthusiastic about a repeat operation as we were about giving it to him, so he was our first case. This shows his, you can see his Pisa radius here is 6.3 almost, so pretty torrential MR. And this is a slide I borrowed from Dr. Moat, and what we're doing here, we didn't record this on our patient, but the finger, we're pushing the finger in the apex to make sure that we have topically the same point that we chose on CT scan and by echo. And so here you can see we're pushing on the long axis, and it's not at the true apex, it's off there. One of the other things is when we plan our incision is we want to go so we're looking up at the heart, because in this case, you can't lift the heart up and make a little purse string like you do with a transapical TAVR, because you've got to keep this in this direct alignment that you're going to have the device deployed in, so that again, you're not pulling it over toward the septum. So here's a device going through the mitral valve, and you can see it's good size. It occupies a fair amount of the orifice, but here's what's again showing the valve introducer here. So the device itself, as you saw back there, can distort the mitral leaflets, and here it can either aggravate the mitral regurgitation, producing hypotension, or sometimes it can even make it better. In this case, the valve, the introducer, is over in the P3 area, and it made the regurgitation better, but that's not where we want it. So here's the tip of the valve in 3D starting to be deployed, and then on the next view, you can see the little tapeworm coming out here as it's really starting to come in. And just about this point is where we start to find our orientation. You remember the little wings I told you about on the design of the valve? As the valve starts to come out, they look like little horns. And we use those horns to orient the valve axially so that we're placing it with those toward the commissures. And so it's centralized, it's coming out there, much like doing a mitral clip. And here we see the valve partially deployed in the atrium. And we're working on our orientation, we go back and forth from 2D to 3D echo. You can see it's not seated yet, but the valve is working already. And that's why this deployment is so easy, so relaxed. The only big issue is the apex. So now the valve has been seated down. It's still not completely deployed, but we have it intraannular. You can see it's still rocking a little bit there posteriorly. And now the valve is fully open. You can see still some activity with the wall pulling away from the valve in these areas, but as you'll see, that's not really an issue. So here we're checking. You can see anteriorly the valve rocking up here, but there's no paravalvular leak. It's well sealed. And posteriorly. And so we determine the appropriate amount of tension to put on these tethers. It's about 5 pounds. You don't want to overdo it and totally deform the ventricle, yet you don't want it too loose to where the valve is going to be rocking. And then we do a pressure challenge, and here you see that the valve is still working fine. There's no paravalvular leak. Valve is opening very nicely. It's a very pretty valve. No transvalvular gradient. 3 is about what we normally measure on these. It's been consistent throughout the study. And no outflow tract obstruction. This shows a valve in place on that first patient. You can see it sits nicely. It looks huge in here. Here's the little tether. The button is resting right here. This is a little titanium bolt that holds the tether into the into the button there, and even at this point, we can still recapture and remove this valve. Even though it's completely deployed, we've cut the tether, it is still retrievable. And this is on another patient showing the baseline and then post-LV-gram. You can see, if you take a close look before the injection of the dye, you can see the stent over there for the valve on the right-hand side. It looks big, it's in there, but it is not interfering with the outflow. So one nice thing about a small study, you saw a lot of very commendable large studies, is there are not a whole lot of data slides. And so in this group of 21 patients, the implant time is not very long. And actually, we did 2 cases back to back. Our first implant was a little longer. The second one took us half as long. So it really is not a long procedure. Length of stay is our length of stay was 5 days, and these patients need to be anticoagulated. You have that cloth covering, which aids in protecting the leaflets as well as incorporation into the tissue, but you have to anticoagulate these people, and I think this was the downfall of the Fortis, but also is something we need to be aware of. Discharged, most patients went home. There are 2 patients who did not receive valves in this, which I'll mention here in a second. All the patients were class 2 and 3, and the only 2 who did not improve initially were the 2 patients who did not have implanted devices. So like any great idea, once you really get rolling in something, you all of a sudden encounter some things that are further down the road that you had not anticipated, and you learn some of the nuances of these procedures. So surgical complications in the study, I'm happy to say we did not create all of these. We did see some of them, but so one patient who did not receive a device had persistent LV outflow tract obstruction, and the device was retrieved and the apex was secured, and that was that. There was one patient who was the class 4 patient at 1 month who had sustained VT during plate. I'm sorry, this is not this patient. One patient had sustained VT requiring cardioversion. You see ectopy quite frequently, but this was one case that required cardioversion. The one patient who did not receive any implant was a patient who had persistent hypotension. We see it frequently with distortion of the mitral valve. This patient had it from the beginning, could not be controlled, and the device was not even inserted in him. Apical bleeding occurred in one patient who was a little hypertensive, and once the purse string was secured, the bleeding around the cannula was controlled. So serious adverse effects occurred in 3 patients, TIA in 1, and more importantly, 2 patients had valve thrombus, one of which was one of our patients. We had, this was the lady. She went home uncomplicated, came back for a 1-month follow-up, was doing great, had no complaints. On echo, her gradient had gone from 3 to 10, and there was a suspicion that there was something wrong with the valve, but given all the hardware in there, echoes are very difficult to do after these things are implanted. So we got a 4D TEE on her. And what you see here, I think if you look at this one, this is the clearest one. You can see that 2 of the leaflets are not opening, they're thrombosed. And here you can see thrombus under the leaflets here. And on this shot here, you can see clot here underneath the device. Again, you've got this cloth-covered structure. You have leaflets over it. What had happened, she went home initially with her INR where we wanted it. She was from out of town, and on a return to see us, her INR was 1.7 instead of 3, where we really wanted it to be. So we kicked up her Coumadin since she was asymptomatic. We did not feel like she needed lytic therapy. She came, we got it up to 3.5. She came back in another 30 days for a follow-up, and here's her valve. It's opening and working fine. So I think for transcatheter mitral valve replacement, there are a lot of challenges, and the challenges may require different devices for different types of pathology. Severe mitral annular calcification makes it difficult to seat a valve like this. We have, as an off-label, addressed that with Sapien inside of MAC, and that has now actually been done a transseptal approach, so it's coming. Since these other devices are huge, they currently require transapical implantation, although I can see that a direct transatrial approach can be utilized, again, depending on the type of securing mechanism that they have. SAM is potentially still a problem with a large floppy anterior leaflet, But with neochordal devices, those could still be secured down toward the apex concurrently with one of these and correct that problem. Anchoring is going to be an issue whether you have MAC, whether you don't have MAC, whether you have floppy leaflets. Paravalvular mitral regurgitation with hemolysis is something that we'll have to consider with these devices and how compliant they are to the various annular pathologies. Anticoagulation is key. It's the thing that we really can't let up on. And with these particular devices, echo is probably going to be all we need. So this may be something, until it gets to the transapical approach, which we all need to learn with the MitraClip, I think this is going to remain in our hands for some time. Heard a lot of experts today speaking, and I'm not sure I can put myself into that category except by a fairly narrow interpretation of this quote by Niels Bohr. I think our narrow field is really narrow. We know some of the mistakes which can be made in this, but I think actually I like another definition from Bob Hope about experts a little bit better. So with that, I'll finish up and move on. Thank you very much.